When it comes to the lumbar spine, it is important to know the anatomy of the lumbar vertebra, the basic anatomy of the bones. I am skipping for this course because we have to learn a lot. So hope you have learned in the basic course. And I am going only for the ultrasound related things that it will be easier for me. But in any area, if you have any problem in understanding the things, you can always ask me and I will go to the basics again. No issues. Now, if we look at the lumbar area, so what are the procedures we do with the lumbar area? The most commonly done procedure is definitely a medial branch block and the facet joint injections. Now, anyone can say that fluoroscopy is doing these blocks very beautifully. Then why ultrasound? Now, in a number of cases, we found that ultrasound is a very cheaper option. And when we are doing only just OPD without taking the patient to the OT, we can actually do the diagnostic blocks under the ultrasound guidance, and it has shown good result. There are some studies also which actually have shown more than 90% success rate when compared with the fluoroscopy. So it's not a bad technique, but only problem is it requires a lot of time for the physician to learn. So if you once you have learned properly, then it's not a problem. You can at least do a very good way the intra-articular injection, because cleft is seen beautifully under the ultrasound, and within that cleft you can inject. Now regarding the next three procedures, like the ultrasound guided lumbar epidural steroid injection, lumbar selective nerve root block, and lumbar sympathetic block, I have written them in a gray line because there is a disadvantage, especially with the ultrasound, in all three blocks. So what are those disadvantages? First comes to the transforaminal epidural steroid injection and selective nerve root block. In ultrasound, we do not have a contrast agent. So big disadvantage in these two blocks is that we cannot exactly say whether we are within a vessel or not. But it is also having advantage. We can see some vessels in ultrasound. We can see some vessels moving in the ultrasound. But the problem is the dye distribution, whether it is epidural or whether it is intrathecal or whether it is intravascular, that can be distinctly understood with the fluoroscopy. That is not being distinctly understood here. So we can do an assisted block, but in most cases, we still prefer in these two areas under the fluoroscopy. Regarding to the lumbar sympathetic block, here in a very lean and thin patients, it is possible to do the sympathetic block with the help of the ultrasound. But if the patient is not lean and thin, then as the structure is very, very deep, seeing that structure under ultrasound becomes difficult. So here also advantage fluoroscopy. Now coming to the trigger point injections, definitely I have written in the deep blue because it is really advantageous. Then trigger point injections is very, very useful under ultrasound. Erector spinae plane block is another thing, whether not only the plane block, also the erector spinae trigger point injections, they are also very useful under the ultrasound. So here also ultrasound wins contrast to the fluoroscopy. In QL block, though we use not very commonly in pain medicine because QL syndrome is comparatively rare compared with the erector spinae syndrome. So QL and SWAS syndrome, this also ultrasound gives an advantage because we can see the muscle, we can go inside the muscle, we can go into the planes and all the anterior, posterior, medially, deep posterior layer of the thoracolumbar fascia that we can actually see. So here also definitely ultrasound gives an advantage. So that is the status currently. Definitely with time, the ultrasound knowledge will be improving, but still the problem of contrast that gives big advantage with the fluoroscopy whenever we are going deep to the bone especially, that will remain for the ultrasound disadvantage for the ultrasound. Now, I've already told, but it is just a summary. So what are the problems with the ultrasound? Basically, deeper structures cannot be properly visualized, that we know. Whether a structure is deep or it is behind a bone, in those cases, ultrasound has a limitation. No contrast. I have already explained why. Contrast agent is very important to understand whether it is intravascular or intrathecal or subarachnoid. That part we cannot have in the ultrasound. Another big disadvantage in lumbar area is that there is no major vessel nearby. In ultrasound, two structures is seen very beautifully. One, the surface of the bone, and the other is the blood vessel. Here there is no important vessel going nearby, so there are no landmarks. For example, for the anterior neck, you have seen we have number of vessels that is our guide, and especially for the stellate. In fluoroscopy, you usually avoid the C7, but here we can do the C7 because we can see both the arteries. And vessels also work as a very good landmarks. For example, the celiac plexus block, but the vessel is the main landmark for the block. But here there are no major vessels, so that's a disadvantage comes to the ultrasound. And definitely ultrasound requires a long learning curve. First, you have to learn to see the structures. You have to learn to see the structures in different patients. Then you have to learn to do the interventions. And in the intervention, the first part becomes your hand orientation, because what happens in our dominant hand, we usually hold the probe. In our dominant hand, we are used to do the procedures. But here you have to use both of your hands. That means either you have to use your non-dominant hand for the scanning and dominant hand for the injection, or the reverse. That means you have to use for the scanning. So we have practiced everything with the dominant hand, but here we have to practice that now the non-dominant and the dominant hand both can work similarly. Definitely with time, after 1 or 2 years of practice, it becomes very easy. So it has definitely a long learning curve, and that is one of the disadvantage of the ultrasound guide procedures in the back pain as well. Now, why we use ultrasound? First of all, in my clinic, you can see just in posterior, we have the ultrasound. So whenever patient comes, I usually do and check under the ultrasound. So it's very easily available. You don't have to take the patient to the OT for the CM. So here I have a procedure room in my back with the fluoroscopy, so it is not a problem. But definitely in most of the areas, the ultrasound is there in the OPD, but whereas the CM is usually present in the OT. So that's a problem. So it becomes costly. Ultrasound is cheaper, it's real time, and it avoids the vascular puncture, no radiation hazard. So there are points in favor of the ultrasound as well. Now, parts of lumbar vertebra. We all know lumbar vertebra is kidney shaped. Anteriorly, it is the vertebral body. Posteriorly, it is the pedicle. Here, in the lateral side, we have the transverse process. Here, we have the pedicle. Here, we have the superior articular process. Here, we are having the lamina, and then it goes to the spinous process. So one thing is very important when looking at from the posterior side. I'm just showing because this is important for the procedure perspective, that whenever we are looking from a posterior side, if you look at this portion, okay, I'm showing in the red. So it's a bony part. So we can see one topmost step here. Whenever we will be looking from posterior to anterior, so we'll be seeing this as a topmost part because it's the most superficial. If we put the probe here, so this lower line below is the probe. So this is the most prominent portion we can see at the top. But remember, they are not in all places, because if we move up and down, definitely sometimes there will be the spinous process present, and it will go to the interspinous area, then there won't be any spinous process. And again, we'll move to the next spinous process. So in that way, we will be sometimes, if you see a transverse scan from the posterior side, we'll be able to see this as a topmost step. And the next step will become this one. That means this is the which structure? The next step below we'll be seeing lamina. And the third step we'll be seeing is this one. This is the transverse process. Similarly, when we'll go here, I have told that sometimes we'll be remaining over the transverse of the spinous process, and sometimes we'll be going over the interspinous area. Here also the same thing will happen, that sometimes when we are scanning up and down from the posterior side, sometimes we'll be over the transverse process, and sometimes we'll be over the intertransverse space in between the transverse process. So that is how we have to look at the structures, because ultrasound shows beautifully the bony contours, but it doesn't show the inner structures. But what will happen when we'll go to the intraspinous area, that means in between two transverse process, then what will happen? Then we won't be seeing this structure, this red mark we will not be able to see. Then what we'll be able to see? We'll be able to see this bone. So over the spinous process, we'll be seeing the topmost portion. There, this portion, the below will be remain hidden by the shadow of the lamina. But as we move to the intraspinous and the intralaminar area, then we'll be getting the echoes from the posterior part of the vertebral body. And usually we called this portion as the anterior complex and we called this portion as the posterior complex. In between we have the thecal space with the nerves going by, and laterally they're coming to the foramina. And from this side also blood vessels go. So there are some radicular vessels. In a lean and thin patient, we'll be able to see the pulsations of these radicular vessels as well. So we understood what we can expect in a bony contour of a lumbar spine. Okay. So we have to know from the top view, we have to from the lateral view. So everything, this part we know. Next, we are going for the muscles, ligaments, and nerves. So what are the ligaments that is strengthening the lumbar spine, and what are the muscles that is covering the lumbar spine? So let's go and check. So we are having this portion. I'm not going into detail of it. Then bones I have already shown, but there are two important structures that I want to highlight here. That is the two processes. Now, rest of the things we have all learned from our fluoroscopy knowledge. But there is a process which remains at this part, which is the posterior part or the topmost part of the articular. Here you see in this model, hope you will be able to observe it. So carefully, I'm putting it closer. Okay, I'm putting it further close so that it is easier for you to understand. So if we hold like this, we see these portions are elevated. Okay, these portions are elevated. So we can see from the lateral side also, this portion is comparatively elevated. And this portion is known as the mammillary body. So this portion is known as the mammillary body. This portion is known as the mammillary body. That is the highest point over the articular pillars. And then we have another small projections. Okay, so these projections we can see in the lumbar level only. These are those projections. So it is a little difficult to observe. So these are these projections. I will show in the image. So basically this is the mammillary body. This is the accessory body. So in between this mammillary body and accessory body, there is a ligament which is known as the Mammillo-Accessory ligament. I will show you. So we have to learn about this mammillo-accessory ligament and mammillary body and accessory body, because these two bodies we can see distinctly. We can see distinctly in an ultrasound, and in that area we have a mammillo-accessory ligament as well, under which moves the one of the important branch we block is the medial branch. So in between this mammillary process, here you can see the mammillary process is written. So it's the mammillary process and here is the accessory process. And in between there is a mammillo-accessory ligament under which runs the median branches. And we have to know the acoustic windows. What are the acoustic windows in a lumbar spine? Acoustic windows are the areas in the spine through which we can actually see and with the ultrasound. That means there are openings, natural openings in the vertebral body. When we put our ultrasound probe there, we can see inside. So that is basically the acoustic windows. We have three important acoustic windows that will come across in the lumbar area, and we'll be discussing those as well. So let's go for the vertebral canal. So the vertebral canal is the area through which the spinal cord, and after L1, it is the chorda equina nerves. They are coming down and they are remaining with the thecal space. So they are remaining at the center. So anterior part coverings are the portion of the anterior complex that start from the posterior longitudinal ligament. After the posterior part of the vertebral body, we have the posterior longitudinal ligament. Then we have the dura mater, and then we have the thecal space. And the posteriorly, similarly, we have the ligamentum flavum. Then we have the epidural space. Then we have the dura, two layers of the dura, and then we have the thecal space. So there is a posterior complex and there is an anterior complex. So we will be calling from now on this anterior portions as the anterior complex and the posterior portions as the posterior complex. Now let's see the openings. So what are those acoustic windows? First of all, the very common window through which we have done many procedures from our beginning, especially those who are in anesthesiology, though are actually put the spinal, put the epidural, everything through this window. That is in the intraspinous area. But when it comes to the ultrasonography guided procedures, remember, this is not an area we choose for, because here as the lumbar spine is actually projected and this area is a little bit obscured because of the hangover of the spines. That means the spines are not exactly horizontal. So it is having a little lower hang. So for which actually it actually makes the foramen a little small. So we do not prefer this window. Rather, we prefer this intralaminar acoustic endo because here we can see the structures very clearly, and here from here we can peep into the vertebral canal, and here we can see the posterior complex, we can see the thecal space, and then we can see the anterior complex as well. And we can reach this area by a view which is known as the paramedian oblique view. So that is the view that we'll be using while we are accessing through this foramen. That means whether it is epidural or spinal, we can easily do from this area. Because this area, if you go interiorly, ultimately after the ligamentum flavum, it will come to the epidural space and it will come to the subarachnoid space and so on. So we'll be using this space maximally. So whether it's the ultrasound assisted spinal injection or ultrasound assisted epidural injection in those areas, intralaminar obviously, we can use this window. Now, the third window is definitely the foramen that we are not going to discuss because foramen injection under ultrasound I'll be showing, but it is not a very common procedure that is done. Next, coming to the what are the ligaments making it stronger. So, if we just count the ligaments, we have the anterior longitudinal ligament, which remains anterior to the vertebral body. So, let us show in the model. I'm taking the smaller model now. Oh, that is very difficult to handle. So, it's a smaller model. So here in the anterior portion, from this area goes the anterior longitudinal ligament. We have the posterior longitudinal ligament remaining the posterior part of the vertebral body that I have shown while I was demonstrating the anterior complex. So PLL first starts with the posterior longitudinal ligament. Then we have the ligamentum flavum that is there here in between the laminas. They are covering and they are guarding the epidural space and the thecal space through the intralaminar area. Then we have the intraspinous ligament. Intraspinous ligament remain in between the spinous processes. That means here first we'll be having the supraspinous ligament at the top of it, okay, and then we'll be having the intraspinous ligament. But here also in the lumbar area, intraspinous ligament is not fully seen because of the fact that here also the spinous are slightly towards the lower side, so it will obscure a little at this point, okay. Then come to the supraspinous ligament. Then we have the intertransverse ligament, supraspinous remaining just above the spine and intraspinous in between the spine, whereas the transverse one between the two transverse processes from here to here, we have the intertransverse ligament. We have the iliolumbar ligament which remains below at this area, and then we have the capsule of this facet that is known as the facet capsulary ligament. So these are the ligaments we are having in the lumbar area. Now let us see a little bit more. So here in this picture, a few ligaments will be very clear to you. So anteriorly, just anterior part of the vertebral body, we have the anterior longitudinal ligament. Then we have the just posterior to the anterior longitudinal ligament, we have the vertebral bodies and the discs. Okay, discs definitely have the nucleus and the annulus. Not going to repeat because it's not required for us. Now, just posterior to the disc and the vertebral body, it is going the posterior longitudinal ligament. And here, remember, a lot of portions of the vertebral body are cut. So here, from the posterior side, we can see the ligamentum flavum from the anterior side. So basically, we used to see the ligamentum flavum from the posterior side, but as it is a picture from the anterior side and a number of portions is cut from the anterior side, like from this area, the vertebral body has been removed and it is cut at the level of the pedicle. And so these are the pedicle, and here it is, you can see these areas are basically the ligamentum flavum from the anterior side. So basically, here we are looking from the epidural space towards the ligamentum flavum. Now, if you go to the lateral side, these are the transverse processes, and in between the transverse processes, we can see these are the intertransverse ligament. Okay, but remember, it's not the ligament. Apart from the ligament, we have the intertransverse muscles as well. Okay, intertransverse lateralis and the intertransverse medialis. So both the muscles are there, and in ultrasound, we see those muscles as well. Now, these two already I have demonstrated and described, so I'm not repeating. So this is basically the supraspinatus and the intraspinous ligament. Here it is the ligamentum flavum. Here is the picture what I have already shown. So basically this part is the Mammillary body, this part is the accessory body. In between, we have the mammillo-accessory ligament. Mammillo-accessory ligament is an embryologic remnant, basically, for the transverse spinal ligament. In 10% cases, it could be ossified, and in those cases, what will happen if it is ossified, especially in the old age? Sometimes you have seen that in old age patients, we usually do not getting any stimulation. So what happens? We are putting the needle here, but because of this calcified ligament, we are not able to stimulate it at a lower voltage. In old age, it is not the only cause, but definitely it is one of the causes, because in old age, there could be neuropathy of this nerves as well that can also increase the stimulation voltage. But one of the causes is definitely the ossification of the mammillo-accessory ligament, making it inaccessible. Okay, so if you are thinking we are close to the nerve, but actually we are not, we are a little away from the nerve. So that is another problem that might occur in the old age. Now, another problem it might cause that sometimes this calcification causes compression over the medial branch. So it can cause pain in the chronic back pain, which is similar to facet pain because of the calcification of this mammillo-accessory ligament. So it is very difficult to diagnose, but here we have to remember that in a small number of cases, it is also possible. Okay, so it can be a possible source of back pain. So it's a cadaveric dissection I have taken from this study. So here, basically, this is the medial branch and it is the mammillary process. This is the accessory process. This is the mammillo-accessory ligament, and here it is the L1 medial branch going. So basically, what will happen if this ligament is calcified? When we are doing procedure, we may fail to reach to the medial branch, and ultimately it could be a failure while we are trying to do a block here. So it might happen that we have done an intra-articular facet joint injection for the diagnostic block, but while doing the radio frequency, we have actually unable to reach the medial branch. So in those cases, we might fail, our procedure might fail. So that is one of the causes of the failure of the procedure here, because where the diagnostic block intra-articular is working, when we are going for a radio frequency, it is failing. It is one of the causes. Now coming to the muscles. The most superficial ones are the latissimus dorsi. Next, we have the part of the serratus posterior inferior, which can go up to the L2. It is slightly up. So basically, in the mid level, there are two muscles: serratus posterior superior, which remains at the thoracic area, and in the lower level, we are having the serratus posterior inferior. But it is not an important muscle for this area, so we are not going to discuss it. Latissimus dorsi is superficial flat muscle like trapezius of the upper extremity. So it can also have the myofascial points here. So these are very superficial, and we can actually diagnose this sex as well. Now, if we look at the deeper muscles, we are having the erector spinae. Mainly three muscles together forming the erector spinae. They are the longissimus, intercostalis, and multifidus. Now, where they remains? Remember, iliocostalis remains slightly lateral and superficial, whereas the longissimus remains medial and superficial, whereas the multifidus remains slightly deep. Okay. Next, we are having the quadratus lumborum, which remains slightly laterally. In fact, when we go with the shamrock sign, we will be able to see the quadratus lumborum clearly. And anteriorly, just anterior to the transverse process and the intertransverse area, we have the psoas major muscle. Remember, psoas major muscle is very important muscle because psoas myofascial can cause compression over the lumbar plexus and can give respective symptoms as well. Okay, so that is why it is important to know about the psoas major muscle as well. Now, if we go for the deepest small muscles, then we have the intratransverse spinalis lumborum, rotator longi, rotator brevis, intertransversalis, medialis, and intertransversalis lateralis. These two muscles we can easily see under the ultrasound. So we'll be showing these two muscles as well. Now, if you look at the MRI, then we can see this portion. Okay, I'm making these areas one by one separate. So here we can see this is the psoas major. Okay, so this remains just by the side of the vertebral body. Anteriorly, we are having the IVC and aorta that we can see. So this muscle is the psoas major. Then we have the quadratus lumborum, which takes origin from the this area. That means it is taking origin from the spinous process. So here remains the quadratus lumborum muscle. Now, here we are having basically three layers of the thoracolumbar fascia. Anterior to the quadratus lumborum is the anterior layer. the medial layer, this is the posterior layer, which is going up to the spinous process. And then we are having at this area, these are the erector spinae muscles. Sometimes it is a little bit difficult to differentiate all the components of the erector spinae, but usually the medial and inner component is the multifidus, whereas the posteriorly we have the other two muscles. Okay, so we have understood this area. Now we all have heard about the shamrock sign. So what and where is that sign? Okay, so basically, if we look at carefully, first see this quadratus as one clove, then erector spinae as another clove, and psoas as the third clove. Okay, so it looks, and the stem is formed by the transverse process. So when we see from the lateral side, and basically we see all these three structures, this is known as the shamrock sign, and it appears like the club sign of the card. So it will be looking like this. Okay, not exactly, but you have to imagine this part, so that will be looking like the club sign. Okay, so now, so in this MRI, we have understood this important areas and this important parts, which is actually a little bit difficult to understand in ultrasound, but definitely we see. This part I have already shown to you. So this is the posterior portion, and this is one component. This is the quadratus lumbar, sorry, this is the erector spinae. Then here we have the quadratus lumborum, and here we have the psoas major. And this is basically the thoracolumbar fossa, anterior layer. Then we have the middle layer, and this is the posterior layer. Okay, and by the sides they are actually getting attached with the transverse abdominis and the internal oblique muscle. Okay, so these are the structures that we have to know in the third part. Now coming to the probes, which probe we are going to use? Remember, in the lumbar area, in most of the patient, the probe we use is the curvilinear probe. Why curvilinear probe? Because structures are deep and those structures can be better visualized under a curvilinear probe. Linear probe can be used only in linear thin patients in the lumbar area. Otherwise, in the linear probe, we won't be able to see the deeper structures clearly. But definitely, the resolution remains high. Now, what are the procedures that we commonly do in the lumbar area? So first of all, will we do under ultrasound the spinal epidural, erectospinae QL block? These things I have already told you, so I am not going to in detail. Facet, both type of facet, quadratus lumborum or psoas trigger point injection, root block or the transforaminal epidural can be done, and the ligament injections if there is the intraspinous ligament inflammation or the supraspinatus ligament inflammation, that is also a cause of back pain, and that can be diagnosed with the respective ligament injection. Remember, this is also a very important part, because just a few days back my friend's daughter came, and she is having young patient adolescent scoliosis, not operative because the angle is slightly less. So there was a dilemma that this type of scoliosis usually doesn't cause pain, but why the child is having so much pain? Okay, so he came to me, and what we have done, just initially we have done palpation under fluoroscopy and ultrasound, then we injected in the intraspinous ligaments, and the patient pain was relieved. So basically, because of this abnormality or the bony abnormality, the patient having more strain over this ligaments, and this also became inflamed, that sometimes can occur. And sometimes the patients also get confused what structure is causing the pain, doctors also get confused. So that